Good morning, friends. Welcome back to my YouTube channel Medical Classes by Dr. Srinidhi Kumar Acharya. Don't forget to subscribe the channel and also please give your valuable comments. And you can also visit the playlist. In the playlist, we have provided almost all the topics in a systematic order. You can make use of it. Anyway, thank you very much. So, we come back to nephrotic syndrome. The last 7 classes over. Now, this is 8th class. Now, let us see. We have seen that complete development of nephrotic syndrome with all the triad like hypoalbuminemia, hyperalbuminuria or heavy proteinuria, dyslipidemia, okay, edema, generalized anaphylaxis. So everything has been developed. Now today we'll discuss, and we have also seen that not only the proteins, albumin, globulin, etc. is going out. The substances like transferrin, which is very important for the iron handling in the body, present in the blood, that is also going out, and as a result, we can see any patient of nephrotic syndrome with the chronicity, so they usually develop a iron deficiency anemia also because of loss of transferrin. Now, when the condition further progresses or further worsens, what happens? Not only transferrin which is going out, now some of the other proteins like antithrombin 3, okay, antithrombin 3, so that also start leaking out. Okay, so another protein called as antithrombin 3 that also start leaking out, and when the antithrombin 3 start going out, the blood becomes pro-coagulation. Now antithrombin 3 is required to prevent the coagulation actually. Okay, thrombin is the one which causes the coagulation, we know that. So antithrombin 3 is substance which actually required to prevent the platelets getting coagulated. Now, if the antithrombin is going out, then that particular patient is now more and more prone to develop coagulation, okay, abnormal coagulation also. And if the coagulation develops, there is a tendency of thrombosis. So, patient may also have, the child may also have the tendency towards the thrombosis. Now, see, now the problems are getting bigger and problems are getting worsening, okay. So, when patient is more prone to get coagulation problem like thrombosis, etc. Now one of the important things happen, that is renal vein thrombosis. Okay, so renal vein thrombosis is very common in nephrotic syndrome. Okay, we have to keep it in mind. So renal vein thrombosis is quite common due to this particular factor, that antithrombin 3 factor is lost when the disease become more and more chronic. Now due to hyperlipidemia, the platelets membrane also get disturbed and increases the platelet aggregation and increases the tendency of thrombosis. Now this thrombosis will, further chance of thrombosis will going to increase not only by the loss of antithrombin 3, but also when the lipids are more in the blood, that adversely affects the platelets membrane. Okay, so because of the coating of these lipids over the platelet membrane, the chance of getting a clotting of this platelet is also more. So dyslipidemia also increases the chance of thrombosis. Sometimes the complement proteins are also lost in the urine. So now antithrombin 3 is going on. It is also going out. Okay. Now some of the important immune cells, for example, complementary fixation proteins are there. Some 23 proteins are there. The total 13 23 cascade of proteins are there. Now these are the very important part of the body immune system. Now when the hole become bigger, permeability become more and more, damage is becoming more and more, even the complementary proteins also start losing in the urine. So immune factors are lost, leading to more chance of infection. So we can see a patient of nephrotic syndrome is always having more prone to develop a recurrent respiratory tract infection, because in the chronic stage what happens, he is losing the proteins. He is losing the proteins, not only proteins, he is losing the immune cells in the form of complementary proteins. So a patient can develop recurrent respiratory tract infection, pneumococcal infections, recurrent pneumonias. So they are very common. Especially the pneumococcal infection is quite common in such patients of nephrotic syndrome, because pneumococcal bacteria, they are encapsulated, they are capsulated, and they require the complementary system protein to fight. So whenever the capsulated bacteria attack, for example, this pneumococcal, streptococcal, etc., more than the streptococcal, pneumococcal. So to fight against this capsulated bacteria, body immune system need complementary system. Okay, complementary system proteins. Now, if the complementary system proteins are losing in the blood, losing in the urine, and body is facing deficiency of these complementary fixation proteins, then definitely this capsulated bacteria cannot be tackled, and chance of getting pneumonia due to pneumococcal origin. So that is very, very common. So usually these patients have frothy urine due to the more protein. Now, if you look into the urine, of course, by investigation you come to know that there is protein, but otherwise also, if there is more frothiness in the urine, that is usually nephrotic urine. Okay, well, the reason is the proteins which are present, they produce the frothiness. Proteins always produce the frothiness. Now we come to the fourth situation. What happens? Now, not only albumin going, globulin is also going, transferrin is also going, so many other proteins are going, antithrombin is going, complementary fixation proteins are going. Okay, now when you come to the next situation, in the fourth situation, this is considered to be very severe injury. Injury is very, very severe, and there is a severe inflammatory lesions are formed in the glomeruli. Okay, and maybe immunological or whatever. Okay, so there is the damage to the glomerulus is more. Now what happens? Now membrane has got some big holes now, and every type of protein can go out. Now the situation is like that, the holes are very big, and there is no holding of the proteins, okay, or getting back these proteins. Everything can go out. Okay, so protein will come down, and even the RBC also now start coming down. Previously it's only transferrin coming, complementary proteins are coming. Now even the RBC can also pass through this. Now when the RBC also start passing through the urine filtrate, then it develops hematuria, which is of glomerular area. Hematuria will develop. So this RBC slips through these glomerular holes and come all the way down, getting a shape of the star, because when they're passing through the narrow nephron area, so they get compressed and all, so they get the shape of the star, or their shape will be disturbed, is maybe dimorphic or dysmorphic, and will denote their glomerular origin. Okay, so that means if RBC, which is seen in the urine, if it has get a shape a star or dysmorphic, its shape has been changed, it suggests that its origin is from the glomerulus, its origin is not from the collecting tubules, etc. So this helps to do the DD with other conditions. So in further course, they are get blocked by the loops and get collected and stick together, and then it forms the RBC cast. So this star shaped dysmorphic, this particular RBCs, when they further travel down, so they are collected together, okay, because stuck it off, because they are not of the biconcave shape now, so they cannot move. Okay, so they are stuck it off, and they come together and clump together, and then it is called as RBC cast. RBC cast. Epithelial cast is different, RBC cast is different. Epithelial cast is seen in case of glomerular acute glomerular nephritis, glomerular nephritis. Here we find the RBC cast. Now further look into the fourth situation now, due to all these obstruction, now this RBC cast they are present, so they also cause obstruction to the lumen now. So because of all this, there is obstruction and the blood flow is now reduced, leading to less GFR. And total urine formation is less, and now it leads to oliguria. As the filtration is less, the total loss of the protein also now less. See, previously the filtration was normal, there is no obstruction, blood is coming normally, okay, but now the situation is different because of different types of obstruction which is taking place in the glomerular area, and even the obstruction which is taking place in the renal veins or renal arteries, etc. The total blood which is reaching the glomerular filtration area is less, number one. Number two, there is no question of no filtration, effective filtration at all. It is totally get damaged. So glomerular filtration itself is very less. No filtration is taking place now. Okay, because mesangial cells and our other cells, podocytes, everything is get damaged. So no filtration taking place, and even the glomerular endothelium is get damaged. So there is no effective filtration. Okay, when there is no filtration at all, then there is no protein loss also, because through the filtration, filtered fluid only the protein is going on. So in this stage you can find less protein in the urine, but it does not suggest that patient is recovering. So as the total filtration is less, total loss of the protein is also less, but situation get worsened. So if all the nephrotic symptoms are reducing, and hematuria etc. is developing, it is a bad news. Okay. Other symptoms of nephrotic syndrome like edema and even the passing of the proteins, etc., proteinuria is decreasing. But patient is developing some new symptoms like hematuria is developing. Patient is developing some new symptoms like hypertension is developing. Okay, if the patient is developing new symptoms like oliguria is there or anuria is there, now this is totally a bad news. Okay, now when the urine formation itself is less, blood urea and creatinine now get increased. Now another set of problems start. Okay, it's not, urine is not filtered. No, so far there is no problem with the blood urea and as well as creatinine, because that portion will be handled by the later part of the nephron, not by the glomerulus. Okay, but now as the blood filtration itself is less, now in the blood urine and creatinine levels start increasing, and this condition where the urine formation is less, blood urea is increasing and creatinine is also getting increasing, this condition is called as azotemia. So blood flow is reduced, so renin system is now stimulated. Okay, natural it is. So when blood flow to the kidney is reduced, renin system is get stimulated and angiotensin 2 is increased. Angiotensin 2 is increased, and now the patient develop a hypertension, because angiotensin 2 is very important. So we use angiotensin blockers, isn't it? So it increases the hypertension, blood pressure, so it may lead to hypertension, and the patient condition is now getting worsening and worsening. See how the set of the symptoms which start as the disease become more and more progressive. Okay, so now what happens, now when the blood urea increased, yeah, blood creatine, urine creatine is increased, there is anuria is there or oliguria is there, hypertension is developed. Okay, complementary system proteins are losing, and even RBC casts are formed. Now this condition is not called as nephrotic syndrome. Now this nephrotic syndrome is now becoming nephritic syndrome. Whole nephron is get affected. All the nephrons are get affected now. Therefore, blood urea and creatinine is also increasing. So now it is no more called as nephrotic syndrome. Now it is called as nephritic syndrome. Now we come to the last stage, that is final stage. Now there is a severe inflammation and destructive injuries, and lot of fibrin molecules are get accumulated because severe inflammation has taken place, severe damage taken place. Now in the glomerular area, what happens? So many fibrin molecules are get accumulated as a as a compensatory mechanism. Now these breakdown molecules of the fibrin molecules stimulate the epithelial cell growth factor. The breakdown molecules of the fibrin molecules, they will stimulate the epithelial cell growth factors. So along with that, there is platelet accumulation, mesangial cell activation due to severe injury, producing more and more connective tissues, which produce a lot of growth factors. Now all the epithelial cells, they start proliferation, and macrophages now also start proliferation. Okay, so within few weeks, what happens is the urinary space is full of cells. In the nephrons area, the urinary space, so that is full of the cells, and they make a cellular crescent. Now this stage is called as a crescent glomerular nephritis. After nephritis, this is the next stage, final stage, where there is formation of crescent glomerular nephritis. Now, the patient develops rapidly progressive loss of kidney functions. At this stage, the patient rapidly develops the rapidly progressive loss of kidney functions. Now, along with a lot of blood urea and creatinine, accumulation of the potassium, etc., okay, blood is also giving rise to the picture of renal failure. Okay, there is because filtration is get affected, potassium is increasing, hyperkalemia is going on, hypertension is there, accumulation of the epithelial cells, crescent is formed. Okay, urea, creatinine is increasing. Now this gives a picture of a renal failure. Ultimately, there will be development of uremia. Azotemia is converted into uremia. Previously, there is only azotemia. Now it is converted into uremia, where blood chemistry is completely disturbed with the symptoms of renal failure. So this develops in a short time. This particular last changes that takes place in a very short time. Therefore, it is called as rapidly progressive glomerulonephritis. Okay, so this is the final most stage, rapidly progressive glomerulonephritis. Now it is not nephrotic now. Okay, after nephritis, now we will call it as nephritis only. After the development of nephritic syndrome, it is called as nephritis only. So now it is rapidly progressive glomerulonephritis. Clinically, the patient will be there with the acute renal failure. Acute renal failure. Now, if you come to the last stage, rapidly proliferating glomerulonephritis, in case any one of type of the injury, if there is that, it becomes chronic, then the inflammatory cells start proliferating and significant proliferation of the fibroblast and get collagens, get accumulation, disturbing the glomerular function. Are undergone the fibrosis and tubules get atrophic? Yes. In the next stage, what happens? Because of all these changes, the tubules, they undergo atrophic, fibrosis and atrophic. Now this stage is called as a hyalinization of the tubules. This is called as hyalinization of the tubules, and this is called as chronic renal failure. This leads to chronic renal failure. Many patients come with a chronic renal failure and the cause is not known. Okay, many patients comes to you, children, so they come to us in the chronic renal stage and we exactly know what is the cause for that. This may be one of the cause for that. So in the next class we will see the complications. Thank you very much.